So good evening, everybody, and welcome to this is the fifth webinar of the iBreastBook series. So this webinar is mainly on qualifications and fellowships. So we have a fantastic lineup of speakers. We have Prof Lynda Wyld from Sheffield that's going to talk about the European Board in Breast Surgery. We have Sudan from University of East Anglia that will talk about the master's degree from the Oncoplastic Breast Surgery from University of East Anglia. We have Sarah Downey who's going to talk about the National Oncoplastic Fellowships in the UK, and Giuseppe Catanuto is going to talk about one of the fellowships, the International Fellowship that they run between Italy, England, and also the States. We have Patricia Clark from the States who are going to talk about the training and the opportunities in the USA. And we have Prof Jaume Masia who's going to talk about the master's degree that they run in Barcelona. On the panelists, I'll be moderating with my friend Omar from Egypt in Cairo, and we have Anne Tansley from the UK, from Liverpool, and Edward St. John that will be helping as a panelist on this. So we'll start with the first talk, and I think the first talk is with Prof Lynda Wyld. Linda, do you want to, the floor is all yours.
Yes, hello, hi, and thank you everyone for coming, and thank you in particular to Yazan for inviting me to do this. So can everybody see my screen now?
Can see it all up.
Yes.
Yeah, okay. So so I've been asked to talk about the European breast exam. I'm the Secretary of the European Exam Board and a surgeon working in the UK. No conflict of interest. So why do we need a European breast exam? Well, I think the reason is that breast surgery has changed enormously in the last 50 years. And as I'll show you in a minute, I don't think training has really kept up with that. This is what you would have had if you were a patient with breast cancer in the 1970s. You would have either a left mastectomy and axillary clearance or a right mastectomy and axillary clearance. And essentially that would be the only treatment that you had. Nowadays, the options for mastectomy are extensive. Multiple different options for reconstructing the breast, all of which require skill and training. Similarly, lots of different options for conserving the breast, volume replacement, volume displacement, lots and lots of different techniques for therapeutic mammoplasties, and an ever-expanding array of perforator flaps. And we even have options for conserving the axilla now as well. So no longer does every woman get an axillary clearance. And there are complex algorithms which are getting more and more complicated as more research comes out. And this is before we start discussing the different adjuvant regimes and neoadjuvant regimes and all the different systemic therapies that are constantly being evaluated. So it's a hugely complex specialty as opposed to 50 years ago when it was a very, very simple one. And breast surgery training, as I've mentioned, hasn't really kept up with this. It's currently just a small part of general surgery or gynecology across most of Europe. And some trainees will spend just a few months doing breast surgery. And at the end of that training, we'll get a CCT certificate, which allows them to treat breast cancer in Europe. So I would say that it's no longer fit for purpose for that reason. There are also, in addition, huge variations in the way we train surgeons across Europe. So it's variable according to specialty. So could be part of general surgery, could be part of gynae, could be part of plastic surgery. The length of training varies, and there are also variation in the rates of people doing fellowships. This is some work that we did a few years ago, looking at the length of training in cancer surgery generally across Europe. And it varies markedly according to the degree of deprivation or the sort of wealth, if you like, of a country, using something called the Human Development Index. And you can see here that length of training in highly developed European nations can be up to 7 years. And this is specialist training with 1 or 2 years in a specialist fellowship to acquire super specialist skills within a subdiscipline, but can be as little as 4 years with no fellowship in some countries in Europe. So quite marked variation there. We also did a survey of breast surgeons working in Europe to find out how many of them had had specific qualifications in breast surgery, and only a third of breast surgeons have a specific qualification. Only a third have trained in a formally recognised breast unit. And only 60% of European breast surgeons, and these are people who self-identify as breast surgeons, offer reconstruction. And this is one of the reasons why rates of reconstruction are highly variable across Europe. And it's also probably a contributing factor to the fact that there are differences in survival across Europe. Obviously, this is multifactorial and will also vary according to the wealth of that nation and the way their health services are organised. So how can we help? Well, there are various strategies that could be used to try and harmonise and improve the quality of training. One thing that we don't have in Europe are consensus guidelines like they have in America, where they have the NCCN guidelines. We do have some European regulation for the quality of continual professional development, but we don't have a standardised training curriculum, and we don't at the moment have a standardised examination of breast surgery as a specialty in its own right. So this is where the European Union of Medical Specialists, or the UAMS, comes in. This was established in 1958 to promote the free movement of medical specialists within Europe to ensure the highest standards of medical care. And basically what it set out to do was to lobby to allow people to move around Europe, which at the moment they can do at two time points. Once they can move with their basic medical degree as a qualified doctor, and they can also move as a specialist once they've achieved full training. The problem with breast surgery is that breast surgery isn't classified as a discipline in its own right. So you get your CCT in general surgery or gynecology, you don't get your CCT in breast surgery. And this is where the problem arises. So what does the UAMS do? Well, it's involved in granting CME certification to ensure that the standard of courses people attend is good. It lobbies for harmonisation at a political level, and it also develops professional exams and professional training curricula. So the European Board of Surgery includes all of these different disciplines of surgery: general surgery, thoracic surgery, HPV surgery. There are a whole range of them. And breast surgery started in 2010 as one of the divisions within the Board of Surgery. This is the current board of the breast exam, which is led by Christos Markopoulos from Greece, and we have board members from across Europe. The format of the exam, it has three phases. The first phase is an eligibility assessment, where we see whether or not you're eligible to sit the exam in terms of the clinical experience that you have. There's then an MCQ exam, usually in June, and this is hosted in 17 countries as a remote exam online. And then phase 3 is an oral examination, which has 3 vivas, 2 clinical scenario-based vivas and 1 academic viva. And this is usually held in September each year. Just a little bit about the eligibility assessment. This is done online, so you submit and upload all of your various certificates and a CV and a logbook, and that's then reviewed by a member of the board. Usually you get an answer within a week, and we're very helpful, and we will give you feedback about where you're not quite there and what you might need to work on. The deadline for submission is usually at the end of April, and the applications open on the 1st of January. We usually approve about 80 to 90% of people who apply, and the eligibility criteria are clearly stated on the website. The main reasons for ineligibility are not quite having the right logbook numbers. And another problem is that you need to have a publication or presentation specific to breast surgery. Whilst research is a mandatory part of breast training in the UK, for example, and some of the wealthier countries in Europe, it isn't in some other countries. These are the eligibility criteria. I'm not going to go through them all in detail, that the standard is usually that of a newly qualified, somebody who's just gained CCT, or someone who's completed 5 years of specialist training. So you don't need to have your CCT if you're a UK person, for example, so long as you've done 5 years of training, so you can sit this exam around about the time you would sit the FRCS. You need to have attended national and international training courses or congresses, and you need to submit a logbook. The logbook requirements, sort of broadly similar to the FRCS, but not entirely. And one of the sticking points is that you need to have 100 full axillary procedures, and that can be made up of both axillary lymph node dissections or sentinel node biopsies, but it has to be a minimum of 30 of each of those. And with the de-escalation of axillary dissection surgery, these numbers are getting increasingly difficult to get. The MCQ at the moment is held in 17 countries. We are open to adding more to this list, and we can run an exam centre for a single candidate, as we did last year, as we had a candidate who was in the later stages of pregnancy and couldn't travel. So we set up an exam site specifically for her. So we're quite flexible about it. And this coming year, because of COVID, I suspect we will be opening a lot more sites because international travel may still be very challenging for people. The MCQ has 50 questions. Some are knowledge tests, some are applied knowledge tests, so scenario-based and problem-solving. It's not just cancer, so we also ask questions about benign disease. And the standard is that of a final year trainee or newly appointed consultant. This is an example of one of the knowledge questionnaire questions for the MCQ. So what would be the absolute contraindication for sentinel node biopsy? And this is an example, of a scenario-based question where we're asking you to look at some post-operative histology and decide about whether or not margins need to be re-excised. So this is an example of the MCQ venue. I think this is the one in Brussels, and everyone has a computer station and they have a login code which takes them specifically to their exam. And then they have a set 2-hour time window to do it. The system is actually very good, it works very well, and people are generally very easily able to use it. This just shows a little bit of information about the oral exam. So the oral exam moves around Europe. So we usually, at the moment, we're having one sitting a year. 2019 was in Bucharest. We were supposed to be in Athens this year, but the exam was cancelled because of COVID, and next year's exam will be in June in Athens. So the exam usually runs immediately after the SO Advanced course, because a lot of the faculty lecture on that course are examiners, and also a lot of the candidates go to the course as a sort of refresher course for it. The exam can run over 1 or 2 days, depending on the number of candidates, and there are 2 clinical case scenario vivas and 1 academic paper viva. The clinical stations are very much like a sort of an MDT scenario, where you're given a case and then you're given 10 questions linked to that case over a 30-minute period. The standard is more specialised than that of the FRCS Part 3 for those of you from the UK, and a higher level of knowledge is required about breast surgery. This is an example of one of the stems for a question. I think this was from 2 years ago. And this one, as you'll see here, is a woman who's had breast augmentation some 15 years ago and has got a swollen breast on one side and some firm lymph nodes in the axilla. And the questions themed around the management of implant rupture and also how you would manage a cancer in a patient with an implant in situ. The academic viva, you're given a paper 48 hours before the exam, so you have time to read it, to digest it, to read around it, to prepare for it. And usually these are topical papers that have been very recently published. So in 2011, we had the Z11 trial and we had Taylor X, I think, last year. So, so they're usually very in the mode, so to speak. The results are given on the same day. There are prizes for the top 3 candidates, and the pass rate for the oral is around about 75 to 80%. So it's not too bad. This is the certificate that you get, and you can also use the post-nominal Fellow of the European Board of Surgery, or FEBS. How much does it cost? €700 for the whole exam, but you pay for it in instalments depending on which parts you do. And if, for example, you fail the eligibility, you don't have to pay the whole 700, you just pay for the eligibility assessment. And if you fail, you only have to pay to take the oral exam again. There's a book which we wrote to support the syllabus that's linked to the exam. And if you buy this, there is a code for people registering for the exam so that they can get a discount on the book. We've also linked up with Brezo. This is a new initiative which was launched this year to try and harmonise breast surgery training across Europe. And it's European Breast Surgical Oncology certification. We want to encourage European surgical trainees who want to do breast surgery to go through this certification system, which has been jointly supported by all of these European bodies, so ESSO, which is Surgical Oncology, the UAMS, USOMA, and a range of other breast organisations in Europe. We've published a curriculum for both knowledge and skills that we think people wanting to do breast surgery should acquire by the end of their training. We've also published criteria for the award of this, and having an exam such as the UMS exam, or the University of East Anglia MSc, or the ESO certification, all are qualifying exams for this certificate. And we also review your training and other issues. And this is the certificate that you get, and that's all I want to say. So thank you very much for listening.
Many thanks for a wonderful talk, Lynda. Lynda has done lots of work for breast education in the UK and across Europe, and she's chaired many things, from the Education Training Committee to ESSO to being the chair of BASO, many other things, and now she's heading the section of the breast surgery exam in the European Board. Has been always a great colleague and has been always very supportive of things. There was one question by Manuel Garefa. I know Manuel, he is one of the consultants now in Derby, I think, and he's asking about, do you expect that the European exam will lose appeal between British trainees after Brexit? And there's a comment that Sarah Downey is going to answer this question live, but I'm not sure if it's Sarah or it's Anne, because Anne is also logged in using Sarah's, so I'm not sure if it's the Sarah Downey, the true Sarah Downey, or is it Anne Tansley is going to wanting to comment on that. It's muted, Sarah, you need to unmute your...
Yazan, it's Anne here. I was just going to comment. Sorry, I've just returned the answer to the panelists and said I'm not sure that Brexit will affect the applications to the European Board exam, because it's still the only way to get qualification in breast surgery in Europe for the moment, and the only way to practice as a consultant breast surgeon in the UK is either getting a CCT in breast surgery, which is the most common way, or in plastic surgery. So I don't think it will have an impact on UK consultants and trainees wishing to sit the exam. That's my personal view.
That's great. There's lots of other things that are on the question and answer online, and we'll try to answer those. Some of them live, some of them by chat. So please, if you have a question, don't use the chat function, use the question and answers function. I've seen that there's a couple of participants that have raised hands. There's about 270 of you online. When we finish all the talks, we might give the microphone to one or two of you. But for time reasons, because we have lots of speakers, we'll just crack on and go with the next talk. Omar? Can you hear me, Omar? I think Omar might have. I think Omar's microphone is not working. His camera has went off, so it might be in a dead spot. So I'll let you use the next speaker. The next speaker is going to be Sudan. Sudan is a great colleague. We've known Sue for years and years, and she's one of the people that helped running the Masters in Oncoplastic Breast Surgery with the University of East Anglia. They have two programs. One is a national program for the UK and was in an international program. And Sue is going to talk about that. So the next 10-15 minutes are yours, Sue. So
Thank
if you want
you,
to share
Yazan.
your screen, thank you.
Certainly. So I hope you can see that.
Yes, that's great.
Lovely. So thanks for the introduction, and thank you for running this wonderful series on the iBreastBook. It's been very helpful for us and also our students on the MS program, so we want to thank you from them as well. So my name's Sudan. I'm the course director for the Master's degree in Oncoplastic Breast Surgery. We've run that from the University of East Anglia in the UK since 2011. I'll just click on. The reason we introduced the Master's degree programme was because the European Working Time Directive was introduced into the UK back in 2009. And at that time, I was actually a senior breast trainee, and we conducted an online survey of the breast trainees in the UK, looking at the effects of the European Working Time Directive on their training and their ability to gain the knowledge they needed to go into their consultant posts. And what they told us was they were having problems accessing the teaching, physically getting to teaching sessions. They were trying to balance their time commitments because they weren't allowed so many hours in the hospital. They had to maximise their operative time. So that cut down on the time available for studying. And they were really having issues in being able to keep their level of knowledge up to the degree that they needed to be able to pass their FRCS and become consultants. So based on this, we developed a blended online learning program to be able to complement their clinical work and be able to allow them to access knowledge, peer debate, expert opinions, but whilst carrying on with their full-time jobs. So it complemented each other. So we've run that since 2011 in the UK, and in 2017 we also introduced a parallel master's degree course, an MCH course for international students or surgeons. And I'll tell you a little bit more about that in a second. We've won a few awards since we started. We've won gold awards for the e-learning concepts that we use, awards for the type of blended education model that we've developed. And also we've started to work with other companies such as Health Education England to develop further courses to support workforce training in the NHS. So our model's been rolled out in the UK outside of breast surgery as well. And this photo here is from one of our award ceremonies, and you can see the course director is myself here, and then our program directors in the centre is Professor Leinster and Professor Pereira, many of you will know. And just to the far right, you'll recognise Mrs Downey, who's my colleague as well, and she'll be talking to you later on about the TIG Fellowships. And I completed a TIG Fellowship back in 2010 in the UK. Okay. So what's the goal of our course? Well, we aim to create an online global community of learning. So we bring together surgeons from all over the world to be able to discuss and share their experiences and best practice really in treating breast cancer, benign breast disease, and being able to work out the best treatments for their women in the situations that they have locally. As I said, it's a flexible online learning course. So people can continue to have their clinical jobs, but be able to access the course whenever it suits them. If they have any downtime at work, in the evenings, at weekends, whenever is appropriate for them. Our standards for assessment are set at a day one UK oncoplastic breast surgeon, similar to what Professor Wyld was saying. So that's our level that we're looking at. We try to develop the core critical thinking and decision-making skills that you need as a new consultant. But in addition, some of the feedback we had from the trainees was that there wasn't a lot of teaching in management, leadership and research areas during their training. So we've also introduced these modules to be able to facilitate people to develop these areas before they become consultants. And that's been very helpful, I think, for the students. And more than anything, the course allows peer group collaboration, networking, and being able to access a panel of very highly expert oncoplastic surgeons throughout the world who facilitate the discussions. So that's been really valuable, I think, as well for our students. The heart of our blended learning is problem-based learning. That's what everything is designed around. And basically, we have a case scenario that's presented, which are discussed by the students in a kind of MDT discussion, which helps them with the decision making, their critical thinking. They have to communicate with each other, and they have to ensure they are able to quote the best practice, the latest papers to support their opinions about how to manage a case. And these are quite complex cases that we give them. I've already mentioned the opportunity for peer networking, and the experts come in to facilitate the forums. They don't teach the students as such, they lead the students in the right direction to make sure they're covering all of their key learning objectives. These are the courses that we offer in breast surgery at the moment. We've got 3-year master's degree programs, the UK Oncoplastic Breast Surgery Program and the International MCh Breast Oncoplasty Program. And this year we introduced a 2-year diploma in aesthetic breast surgery, which has started very well. And a lot of our old students have actually enrolled onto this new course and are quite enjoying it. And this supports aesthetic practice because, again, there is no formal education really available, especially in the UK, on aesthetic breast surgery. So we wanted to introduce that to try and improve the standards. And we're also introducing in January an oncoaesthetic breast course, which I'll talk about a little bit later. It's a more tailored course, so it allows surgeons to be able to choose modules that suit what they want to learn and build those into their own flexible degree. So our learners are based all over the world. We teach now for all our courses, breast, colorectal and regional anaesthesia in 41 countries throughout the world. We take from ST5 level, which is a kind of middle to senior grade registrar level, right through to very experienced consultants. Yeah, we've taught presidents of international breast surgery associations as well as part of our students. So we have a whole range of students. We do need competency in the English language to be shown before we can allow students onto the course, just to make sure they can benefit from the discussions and gain the full value from the course. We don't only offer the 3-year and 2-year courses. People can take individual modules for CPD points to support accreditation. And so far we've enrolled in the last 9 years about 280 students just on the breast course, of which we've had 105 awards so far, and almost 50 master's degrees have been awarded. So it's a flexible course. A lot of students choose to intercalate due to personal circumstances or jobs or exams, but we are very flexible. We allow them to do that so that they can take the course as and when it suits them. Each course is structured very similarly. There are 16-week modules, and these run sequentially. The first one in January, then May, then September, and students can join at any point during that during those modules. We have 4 specialist clinical modules, which run sequentially, and then the 2 generic skills modules afterwards. And following the 6 modules, we then have a practice-based dissertation year, and we encourage publication of this dissertation to kind of facilitate career development as well. So this is just in a pictorial form to show you how the course is structured. In year 1, you'll have clinical modules 1, 2, and 3. Year 2, you then finish your final clinical module, and then you have the generic modules leadership and management and research and service evaluation. And then completing that, you go on to your final year dissertation in year 3. So for oncoplastic breast surgery, which is our main course, these are the modules that we run. We start with benign breast disease, moving on to malignant breast disease, then oncoplastic breast conservation, breast reconstruction, and then the 2 generic modules. Aesthetic breast surgery is a diploma and not a master's degree at the moment, so it doesn't have a dissertation year. But the modules for aesthetic breast surgery are breast reduction, followed by breast augmentation, mastopexy, and then complex aesthetic breast surgery, which is secondary surgery and complications, etc., followed again by the 2 generic modules. And this is the new course we're starting in January, which is oncoaesthetic breast surgery. And this is designed really to appeal to any surgeon who, from plastics or breast, who are looking for more targeted areas that they want to develop their knowledge in. So we're allowing them to choose from any of the existing clinical modules that we run. And they can choose either 3 or 6 modules to build a certificate or a diploma in oncoaesthetic breast surgery. The modules are all structured very similarly. We start with a reading week, and then we have problem-based learning over 2 weeks as scenarios. And these are discussed online as part of the forum discussions. The cases are discussed with the peers, and our experts come in just to facilitate the discussions, guide them in the right direction, making sure that they've got full understanding of the cases. We have formative tasks, and they're just to make sure that students are heading in the right direction and can assess their own learning, make sure they are keeping up with the learning. We have MCQs for this. We have something called script concordance testing, which is a test basically of whether your opinion correlates with that of an expert panel. And then we also ask the students to submit a management plan following the complex case discussion. And this is just to ensure that they are managing the case correctly. They're not going off with any wrong ideas or anything. So it's kind of a safety netting. At the end of each module, there's now a reflective essay. We used to have MCQs, we had single best answers, and we've tried all sorts of assessments, but over the years we've evolved towards the reflective essay. Because we found that this shows a broader range of knowledge, and we also find it's helpful for the students because they can use this as part of their appraisal process as well. So that's been in place for the last 2 years now. This is just a screenshot showing you a typical scenario from one of the forums. This one's in postmenopausal breast cancer. And there's a written scenario regarding a patient case supported by video, evidence, images, etc. The students then go on and they would discuss that case. And as you can see, it's more of a discussion and conversation rather than just posting opinions. So that's what we encourage, really. One of the key differences between the MS and the MCH courses has been that we have had a face-to-face OSCE for the UK and European candidates in the past. And this was held has been held in Worcester for the last few years because it's quite central in the UK. And this is our panel of examiners that we had in 2019. And it's a small picture, but you may recognise some people. We have Dr. Kopika on the end here, who is our Southeast Asian convener. And we go over to Pune as well to help run courses to support the learning for the students in the MCH. And then we have Daniel Leff here, who was one of our old students. He's now a consultant at Imperial College. You've got Professor Pereira there and myself, Richard Sutton behind us, who's a breast surgeon in Bath, very well known, and Stephen Thrush, who his unit it is that we actually go to, and he's one of our module leads. Well, obviously COVID this year made a lot of changes and we couldn't do a face-to-face OSCE, but we didn't want to cancel this because obviously it's a high stakes exam, and we had people who were hoping to graduate with their master's degrees. So instead we developed an online OSCE this year, which we actually ran from the University of East Anglia. So it looks a little bit different to sunny Worcester, but this was our e-learning team back in September. So we have Laura, Andrew and Chris, and they're the 3 people who run the courses from the administrative side. And we ran a very successful online OSCE with still our examiners joining us, and it went very well and there was good feedback. So we are hoping to develop that further later this year and also next year. This is just some of our student feedback that we've had, and really the headlines for that are that they feel that and undertaking the course improve their patient outcomes, and I think this is why we all do it. myself and all the other faculty, we know that at the end of the day, there's a patient at the end of this, and if we can help and improve their outcomes and their options and their choices for surgery, then that's what we're here to do, really. Obviously, the master's degree has helped people with their career progression, and as I've said before, the networking opportunities for this course can't be underestimated. Really, they're extremely valuable. So we have feedback, obviously, from our Indian students there, but also from our UK students, and I'm sure you can read that yourselves. So this is the full range of courses we're currently offering. As I said, we've got the breast ones at the top. We also offer a master's degree in regional anaesthesia and coloproctology, and there are other courses under development at the moment. And we've had interest because of our success in delivering our education through the years from Health Education England, and there's now almost another 40 courses in development to support the NHS workforce development in association with HEE and other organisations in the UK. So it's a very successful model, and we're very proud of it. So if you would like some more information about the courses, the next ones will start in January, mid-January. We've got applied basic science and breast disease, we've got breast augmentation, and we have oncoplastic breast conserving surgery starting. So you can find more information about all of these just on the UEA websites, and I will put my email in the comment section so that any of you who are interested can contact me directly. So I hope that's helpful.
That's lovely. Many thanks for that, Sue. And I'm more than happy to, if you're happy to share your email, for people that want to ask specifically about certain things that Sue and the other speakers talk about, if they're happy to share their emails in the follow-up email, I'm more than happy to put the emails. And also, if you have a link for the master's degree, and if Prof Masia has a link for their master's degree, and if Lynda have the link for also for the European Board of Breast Surgery, I'm more than happy to put it in the follow-up email that will go to everybody that has registered and attended or did not attend. They will get also the same email. I think one question before we go ahead for the next speaker, and maybe if we can get Ed to answer that question, because Ed has just finished training and Ed is one of the consultants in the Marsden now. So how important do you think that something like this, like the Masters in Oncoplastic Breast Surgery, is for trainees? Many people take it, but some people do not take it. What's your thoughts from that point of view, Ed?
Yeah, thanks, Yazan. Well, I really enjoyed hearing that lecture. I guess I think it is incredibly useful, and I know lots of people who've gone through it and loved it. Dan Left being one of them, who was mentioned. I guess I do wonder why this can't be a routine part of our training anyway. And maybe this model has just shown how good education can be in specialist subjects. And I wonder why at ST3 to ST8 level this sort of course couldn't be run. I suppose the answer is expense, but it would be nice if some of the aspects of these courses were brought into mainstream training. But yes, I've heard great feedback. I haven't personally done it myself, but I think there's a good use for it, a good point for doing it.
I always learn when I teach online on the course. I always learn something new each time I teach on the models. But Sue, you chose that photo just after I left that exam. Lynda has chosen a photo where I was in the photo. So I like Lynda's photo much more than yours.
Sorry, Yazan.
Now, the next speaker, I think he's one of the godfathers of microsurgery in Europe and the world. And he's one of the best people that has described super microsurgery, lymphedema surgery. And I had the pleasure of going and doing a diploma in microsurgery in breast microsurgery in Barcelona, and met Prof Masia quite a few times. Fantastic qualification, mainly for plastic surgeons, and everybody thought, why does a breast surgeon want to go and learn more about microsurgery? Because I love it. But also they're on another course, which is mainly surgical oncology and breast aesthetics and reconstruction. So Prof Masia is going to speak to us about their qualification. Prof, the next 15 minutes are all yours. Thank you.
Thank you very much for the invitation. It's a great pleasure to be here in this special session, because I miss that kind of session in the big meetings, because in the big meetings there is not much time to talk about educations, and definitely this is becoming more and more important. I'm going to try to explain how is the essence and the philosophy of this European master degree in surgical oncology, reconstructive and aesthetic breast surgery. As Yazan said, this is a plastic surgery initiative, but this is not, you know, a Barcelona degree. This is a European degree because it's, at the end, the idea and the concept become from different groups of European, you know, plastic surgery department. It's obvious that surgical education changed a lot in the last 50 years, and to be a good surgeon becomes more and more difficult, or at least demanding. And this happens also in this kind of transversal fields, because breast surgery is not a general surgery, a super specialty, it's not gynecology, it's not plastic surgery. I like to say that this is like hand surgery. This is completely transversal field. And this is why what we realize, you know, from many years ago is that there is a lack of comprehensive training in breast surgery. As a plastic surgeon, surgeons, we work with all the oncology surgeons, and we receive the result of the oncology surgery. And we realized many years ago that there was a lack of training, a lack of good approach to the breast surgery. And this is not our view. It obviously is the view that you can find in everywhere, in UK, in US, in South America, in all European. They have many papers, good papers like this paper that was published a few years ago, and it's obvious that the conclusion is there is a great variability in breast cancer surgery training in Europe, because Europe is a mesh, it's a mosaic. You can see, yes, Brexit is not COVID, all different cultures, people from South, people from North, Polish people. This is a great mess, and it's a big, big difference in training. But at the end, what we want is the equity for our patients. It doesn't matter if these patients are Scottish, or are Greece, or are Italian, or are Spanish. And this is why the first question to answer is, what means breast surgery? And breast surgery means oncology breast surgery, obvious. It means oncoplastic breast surgery, because it's completely different than the oncology. Is reconstructive? Yes. Is aesthetic? Yes, because you cannot do breast surgery if you don't have clear concept in aesthetic surgery. And obviously, is lymphedema, because lymphedema, even you do beautiful sentinel lymph node work, still we have a lot of lymphedema breast-related, you know, cancer. And this is why we need to complete, to increase the training in breast surgery if you want to be obviously a breast surgeon. And when you see the cake of the breast surgery, we have a lot of techniques, especially what we have in the last, you know, 20 years. We have increased a lot oncoplastic and reconstructive, and obviously aesthetic, and obviously oncology. But there is a big, big, you know, cake that we need to learn all about. And this is why who is the breast surgeon is who is doing good oncology surgery, who is doing good plastic surgery, reconstructive surgery, and is the one who has at least clear concepts about what means breast aesthetic surgery. Because what you want to achieve is quality of life at the end. And this is why, from our point of view of the plastic surgeons, people who are really focused in breast reconstruction and also breast oncoplastic surgery, we realize that a breast surgeon needs to be trained as a surgeon, as a researcher, as a teacher and a mentor, manager, communicator, and everything. For what? To provide, you know, the best treatment for our patients. And this is obviously what was defined many years ago, that you want to have a breast center, need to provide all the services at the same quality. It doesn't, you cannot give, you know, basic oncological training and advanced oncological training. You cannot provide basic reconstructive techniques and advanced reconstructive techniques. You need to provide all the services at the same level. And this is why we started to think in, this kind of, requirements to provide, the knowledge for these breast units. And this is why we start to work in a very ambitious, independent program to integrate all the points, all the different views of the breast surgery. And as Nelson Mandela said, education is the most powerful weapon that we can use to change, I don't know if the world, but at least our practice and the results in our patients, because still you can see horrible results after breast cancer with or without, breast reconstruction. In our side, in the plastic surgeons side, what we need, it was obviously more surgical oncology training, but at the end, all of this training you cannot provide in a 2 days course, in 1 day course. You need to have a very complete, training program, not to validate, not to give accreditation. It's to teach the people how to do a good mastectomy, skin sparing mastectomy, how to do a good axillary clearance, how to do a good DIP reconstruction, how to do a local flap. That you need to teach. You need to have a very, hands-on theoretical program. And this is what we try to create with different people in different places from Central Europe, UK, south of Europe, Scandinavian countries. And we provide a very ambitious program involving, in that moment that we start this program in 2009, the most prestigious centers on that field. And we make a program that is, at the beginning was 11 modules: breast oncology, clinical training in oncology surgery, dissection cadaver techniques, essential concept in microsurgery, because the breast surgeon also need to have microsurgical approach, dissection techniques on animals, then basic concept of oncoplastic and breast reconstruction, implant breast reconstruction, autologous, aesthetic breast, lymphatic, and a real strong clinical immersion program that for the American people is what you have like a, fellowship. That is, our fellowship is the clinical immersion program. It means it's a period of 6 months, 1 year, or even more in a clinical immersion program in different centers of Europe. And more recently, we have increased even that with another model of, basic research methodology, because all of our, students, they must do a research, study to pass, and to get the accreditation. There are some of the centers like Gustavo in Paris, St. Thomas in London, the Institute Oncologico Europeo in Milan, Zurich, Brussels, Ghent, and we have also now many other centers outside of Europe, because the people, they want to see what the people are doing in Toronto, or what the people are doing in the NYU, or what the people are doing in Mexico City, or in the Asan Hospital in Seoul. And this is what I told you, this is the last module, the 12th module, introduction course on methodology on clinical research. And we have also a master final thesis. We like to provide, all the best education, because at the end, what we want is not to give a paper. It's a way of thinking, a way to treat the patient. And this is not to create another school. We don't want to have more medals and more papers. We want that our people is going to do the best practice in all the patients. And this is what we provide, this teaching method with lab models, clinical immersion, online microsurgery, and the most important, we provide an individual education itinerary, because it's not the same when some people has a previous training in oncology and join to the master, or another guy has a previous, training in plastic surgery or in gynecology. we try to individualize this educational itinerary. We have a very strong on-learning campus that has been very useful, especially now in the COVID time, and we developed many years ago. We have, you know, a kind of app, you know, corner, the people, they can see cases in the mobile phone, in everywhere. And at the end, what we have is this kind of bi-directional and interactive educational program. Our tutoring and mentoring program is very important. Every student has a mentor, and this is the guy who is going to be responsible to teach and to design of this educational itinerary. At the end, what we want to provide with this kind of program is not only education, is not training, it's a kind of personal growth in breast surgery, because this is what we can still miss in many places, and do another international dimension of learning. Inside, you know, the master, we have even very specific fellows, like this lymphedema research fellowship that we developed 3 years ago, and we can only give one post per year, and we have trained very strong people that now are developing this kind of surgery in US or in Egypt, or now in Mexico, and now we have another guy from South Korea. And at the end, what we want is just to help you, because we have only putting a drop of sun in this huge wall of education to help to define the gold standards in breast surgery, at least, you know, from another point, from the point of view of the plastic surgeon, because we can provide a lot of, you know, help in that field, and we try to improve this harmonization and the standardization of the training, and of course at the end the main goal of this European educational program is not to give certificates of paper, it's just to provide equity in breast cancer treatment for all the population, because unfortunately it's not the same even in the same country, depending where you choose the place and the quality of the breast surgeon that you're going to find. And this is the most important thing. So we need to do a lot of work, but we need to do all this work together and to provide the final goal, that is provide the excellence for our patients. Thank you very much.
Many thanks for a lovely talk and lovely presentation, Prof. And I really enjoyed. I did not do the full masters. I did the diploma part of it, because that's all what I wanted from to learn more about diploma in microsurgery rather than the surgical oncology one. I really enjoyed going through the different cities in Europe to do the different modules. That was really an eye-opening thing, and also enjoyed meeting people. We still have a group on the WhatsApp from all the people that did for that diploma between 2015 2017. And we still text each other, people from the Middle East, from Lebanon, people from South America, people from Mexico, people from Spain. It's always, it's a very good mixture of people that attend those things. So many thanks for a lovely talk. So we had the talks about the fellowship, we have the talks about the qualifications and the degrees. Now we have some talks about fellowships. Omar? I think Omar has some issues with his internet reception. Apologies for that. So we'll go ahead and I think, can you hear me now?
Yes.
Do you want to introduce the next speaker, please, Omar? Thank you.
Yes, I would like to introduce our who's working in James Specialists in England, and she will be speaking about oncoplastic fellowships in the UK.
Sarah, can you hear me? I think you're muted now, Sarah. So if you want to...
Yes, that's fine. I'll just share my screen. Thank you. Thank you for the opportunity as well to join this talk. Like Sue, I'm very grateful. She had a photo of me, and this isn't a mutual appreciation society, but Why am I interested in breast surgery and breast training is what I'm going to talk about, and why we give our time. And it was wonderful to listen to Jaume talk with such enthusiasm. And that's one of the things about being part of a faculty, is you meet like-minded people who are working hard towards a common goal. And this is my team that work hard towards a common goal for our patients. There's myself, Guido Curler, who's our plastic surgeon, and Sue, and we're all there in clinic on Wednesday morning with the patients, talking about what their options are, what we think is in their best interests. And we have all that combined experience, which is just in the best interests of the patients. And that's what we want for all of you. I think building the networks has been mentioned a number of times. And if I can't offer what I think is the best, I want to be able to send my patients to the person I know who can offer it. I don't work in a huge unit, but I do have a huge network through both Sue and Guido, and we put it all together for the benefit of the patient. So I trained a number of years ago. I won't tell you how long, but what was wrong? I think these two pictures demonstrate what I did not like. Clearly a wide local excision that is worse than a mastectomy and reconstruction, and then a patient that's left with such asymmetric breasts that she could not put on a blouse. Not acceptable, I don't think. So what have we done? So I'm the chair of something called the Training Interface Group. We have a series of fellowships in the UK that are taken in pre-CCT at the moment. So CCT is the final qualification for surgeons in the UK across general surgery and plastic surgery. And the interface groups are where there are more than one specialty involved in a fellowship. So for us, it's breast and plastic surgery trainees have access to that. And that whole development of the fellowship brings a bunch of surgeons who are interested in training together. So we have a great faculty, we have great meetings between trainers about what's going on, what the problems we face, and again, another network. And then we have cohorts of trainees coming through. I'm sure Teddy would tell you what it was like to be a TIG fellow. I know he's been through that process. Sue did a number of years ago, and we have generally 9 fellowships each year, although I always beg for money and I've kind of got an extra one most of the last couple of years. And we have 14 units across the UK. My role is curriculum development, providing externality for those fellowships, selection and recruitment to make sure we have equity of access across the whole of the UK, identifying suitable centres, so centres can apply and we have a form for that. And then I host an annual meeting, which obviously this year has been online. So these are where our units are. So we have 4 in London, and then we have Portsmouth, Exeter, Chelmsford, Birmingham, Nottingham, Leeds, Manchester, Liverpool, and Newcastle. Oh, and not forgetting Sheffield, sorry, Linda, Sheffield as well. And the students get to choose where to go, and they are supposed to be supernumerary. And we, as Jaume described, try to tailor the fellowship to the trainee. So if they're a plastic surgery, they get lots of oncology. And if they're a general surgery with a good oncology background, they have more access to the plastic surgery side of things. This is the UK training programme. And I have to say, this has been something of my bête noire for the past few years. I sit on our national training committee. And when I was appointed nearly 6 years ago, there are over 20 people on the committee, 1 breast surgeon. So I have been a little bit of a lone voice, but I have so appreciated the support of Anne Tansley, Fiona McNeill, a number of others. Katie Hogben now sits on it as well. And it has been a huge amount of work, and I'm sure you've been through similar things in other European countries of trying to get breast surgery recognised. And for people who are my era, who have trained before breast surgery is what it is now, they have no comprehension of the complexity that we all deal with on a daily basis in our practice. So at the moment in the UK, we have core training, which is usually 2 years. You then have a phase of 4 years, which is based around emergency general surgery and its delivery. So you have a year of colorectal surgery, a year of upper GI surgery. You might get 6 months of breast, you might get at the most 12 months of breast. And then you get 2 years of breast at the end, and quite a strict amount of PBAs, which are training assessments. So you have to be said to be at consultant level and signed off in a number of procedures. So why do I like doing it? So this is a procedure that I learned probably in the last 5 years. It's a Batwing Therapeutic mammoplasty. I removed most of the upper half of this lady's breast because of DCIS, and she's had no further interventions and is very happy with that. She's in her late 70s, but she did not wish to have a mastectomy, which I think is entirely reasonable. Just to give you an idea of some of the numbers of that we get through the fellowship. So I've anonymized all this, but I collect all the data every year. And so a trainee would get between 46 and 101 mastectomies, of which 81 were skin sparing. Conservation with oncoplastic, it's difficult to pick out oncoplastic surgery in the way that our online portfolio works, which we're trying to correct, but that is quite difficult. But I think it gives you an idea of what we can achieve in a year. So as Jaume said, you can't go and spend a couple of weeks in a unit and pick it up. You need to be immersed, as his program describes, so that you get all the input from all the different people working in those centres. These are some of the challenges. We mentioned cosmetic surgery. This lady came with very substantially larger implants than she has now with a left breast cancer, extensive DCIS, needed a mastectomy, and then Guido did the other side and made it some symmetry for her. But these are the challenges that we face. So breast cancer in a patient who's already had either augmentation or reduction. And if you don't understand and know what these procedures mean, you can't possibly offer them the best advice. Going down to some of the smaller detail of what you get through the fellowships. So augmentation, reduction, anything between 20 and 50. Mastopexy is fewer because many of those are done in the private sector, and that's more difficult in the UK to get access to. But good numbers of implant reconstructions and free flaps in each of the units. Again, demonstrating the challenges we face, I always show this patient who was my most challenging patient a few years ago, BMI 42, had a mastectomy on the left, wanted to go to her son's wedding and wanted a reconstruction. She'd also had previous PEs. So Sue helped me do the right-hand side, which was a therapy, a straightforward melon slice, because she had a kind of probably a breast at least twice that size to start with. And we did an implant reconstruction on the other side. She's got an implant that's over 1,000 cc's. The technical skills are not the only part that's important in the fellowship, and Jaume mentioned this too. We look at audit, we look at service review, service development, leadership skills. We need to make sure that everybody has access to all of these techniques, and that it requires all of us to keep working on all the programs, such as the program that Sue has developed, for us to keep moving forward and keep sharing our knowledge, sharing our thoughts about what we can do and how we can improve things for our patients. So research is also important as part of this, and communication, just as is mentioned in the other programs, and advanced communication skills. We have a whole set of quality indicators, and they set out what we expect of each of the fellows and each of the units to provide. And that again includes communication, research, audit, attendance at meetings, clinical exposure, and clinic exposure. So what do I think works well with what we do? The integration between the specialties is fantastic, and is something that I think has been hard fought for and continues to be an inspiration to me. I always learn something new. And the integration between the trainees, I know they all stay in touch, they all talk to each other, and I'm sure Sue's told me about the network that she has from when she did it, which is quite some years ago now. The focus on leadership, there is still a need to move forward. Just as Jaume has described, we have to keep moving our service so that every patient has access to it. And an opportunity to broaden experience by visiting other units and learning from the best. This is a challenge that I've shared with my breast plastic surgery colleague, so a lady with significant radiation damage after a mastectomy many, many years ago, but still wants a good quality of life and wants to know what our options are in terms of having some form of reconstruction. So what remains a challenge for me? Maintaining the momentum. We've had our TIG fellowships now for 20 years, and I just had to go through a process of defending them quite strongly. They sort of said, well, you've already had all these fellows out the other side, surely we need to spend that money on someone else. So maintaining momentum is always a challenge. the constant change, as you will all know in all of your practice, there are constantly new techniques, new approaches, both in oncology, in surgery, around implant and prosthetics, and how we examine those, evaluate them, how we implement them safely into our practice if appropriate. That's all, the constant change is a challenge. The cost to trainees is a challenge. The cost in terms of financial cost and in terms of personal cost when they have to move away at what is often quite a challenging point in their lives where they might have young children. The impact on their families is very significant. And so the constant fight for funding, we have had great funding over the years. From one of the deans, Geoffrey Wright, who has been marvellous in making sure the funds are available and continue to be. But as I say, that does require a rearguard action by myself. And again, I would like to acknowledge Anne Tansley as fighting that battle with me to maintain the funding. But we do, and we have appointed fellows this year who, despite COVID, I've just been through all their portfolios and they're doing brilliantly, bless them. With innovative approaches. We've got applications open at the moment for the next year's fellowships, and we're just making sure that they go forward as post-CCT fellowships in the future to ensure that we continue to develop our workforce. The feedback from those who've been through it is that the excellence of the trainers and that opportunity to meet other people and discuss with enthusiasts, lots of operative exposure they've enjoyed, and particularly the supplementary courses around leadership, communication, and developing their own practice. They very much appreciate the chance to be published and to be part of that academic programme. But as I said, the financial cost is certainly feedback that's come to me on a number of occasions. We did a survey of past trainees, 25 responded, and 92% of them are in a core breast MDT, 36% are in a leadership role. Very few of them do on-call for emergency work, but some do some breast on-call. But they're also very highly involved in national trials, and I think that shows the success of the programme and trying to develop the leaders of the future. So the unique position of the position is that it's developed by both plastic surgeons and breast surgeons, and I really think we need to keep that and going forward that we continue to adjust with the changes to the parent specialties to make sure we offer the best for our trainees coming through. That's me operating with my plastic surgical colleague. It's all about teams and building teams for the future, and building a wider team that is not just within the UK, I hope, that should be across really the world. And that's where I fully support Sue and her approaches, which I think are really bringing us all together. I had the privilege of going out to Pune to teach the students, and it was just amazing to share the stories, to listen to the challenges that face those young breast surgeons coming through, and to discuss approaches that have either worked for us in the past or just to understand the challenges that they face in developing their own practice. Many thanks. I am very happy to answer questions, and Yazan, I'm very happy for my email to go out. I do occasionally get questions about fellowships. I'm also part of our SAC, which is the National Training Committee, so I look at the non-routine pathway for trainees as well, so CSER applications, etc. So I'm always happy to support and offer any advice.
That's great. Many thanks for that great talk, Sarah. I think we will address all three talks on the fellowships, and then we'll ask the question and answer section, because there's lots of questions about eligibility criteria, who can apply, who cannot apply. So instead of repeating the same questions after each talk, we'll just do all the questions after we finish the fellowship section. And any comments about the National Oncoplastic Fellowships and the UK Fellowships before we go for the next speaker?
Just a quick note just to say that with our new general surgery curriculum coming through in August 2021, all of the fellowships that we currently run before you gain your CCT will now be moved to a post-certification qualification as from August 2022, and that's quite a big step for the UK. So all specialist fellowships will essentially be moving to post-certification. So all of the time that you spend gaining competencies for a general surgery certification, you'll then have the opportunity to develop fellowships after that basic qualification to become a consultant is awarded. And that will sort of provide some challenges, and we are very confident that the training program will still be very popular and competitive, because individuals will continue to choose to sort of widen their breadth of experience, because I would advocate for all trainees across the whole of the globe, whatever your local training requirement is to get your certification, you can bolster all of your experience with all of the different things that we've talked about tonight. Doing the master's degree, doing extra qualifications, looking at extra breast surgical programs such as those Jaume has described. Because at the end of the day, you want to provide the best treatment for your patients. And it's incredible how we're now sharing all of our experiences that can be accessed across the whole of the globe. Thank you, Yazan.
Cannot agree more. And I was one of the lucky ones that was a fellow a good few years ago in Essex, and that gives you a network. It doesn't only give you the training, it also gives you the connections and the network. And those fellowships were made possible just because also breast surgeons and plastic surgeons work together. And we really need to acknowledge how much plastic surgeons have done for breast oncoplastic training. My year in Essex, I was mainly with Simon Smith and Sacha Dua, which I loved working with them. But Venkat Ramakrishnan, when you see how he does his microsurgery, you just open your eyes, open your mouth, and just sit there and just appreciate how people can do something like that. And that was the introduction to Prof Masia and to the degree. And those are little connections. You see lots of things you might not be able to do the technique, but when you learn that technique, you can advance the service, which is very important. The next speaker will be introduced by my friend Omar again. Omar?
I would like to introduce our dear friend, Professor Giuseppe Catanuto from Catania, Sicily. He's going to speak to us about international fellowships. Go ahead, sir.
So thank you very much. Can you hear me?
Yes, sir.
Okay, I'm going to share my screen now.
By the way, Giuseppe has just finished his session in the MBN, which is run by himself and Prof Nava in Italy. And just after the session, he's doing the webinar with us. So many thanks for that, Giuseppe. Go ahead.
Thank you very much for the invitation. It's always a great honor to be here and share experiences with you. It's a very interesting possibility. Thank you very much. And I will be talking about the international fellowship, but really I'm not going to talk about the technicalities, the surgical aspects, the surgical skills, and all the aspects. I will be going to talk about a man, a surgeon, a mentor, Mr. Querci della Rovere, the one to whom this international fellowship has been dedicated. Querci della Rovere was a consultant surgeon at the Royal Marsden Hospital in Sutton, and eventually he died while working there in 2009. After a long illness that was born with courage and dignity. And Querci della Rovere was born in Venice, and he really had Venice deep in his heart. And he belonged to one of the most important families in Italy, the family della Rovere. Just to let you understand what this means, they had in their family two popes, Julius II and Sistus the fourth. And just to understand, Julius II is the Pope who appointed Michelangelo to paint the Cappella Sistina in Rome, in the Vatican. And Sistus IV is the Pope to whom the Cappella Sistina has been dedicated. So a very ancient family with such an heritage and historical background that deeply affected, I mean, is something in the background of the personality of this man that I had the fortune to meet during my experience at the Royal Marsden Hospital a few years ago. And Querci della Rovere graduated in Padua, which is one of the most important medical schools in Italy, one of the oldest university. And he trained general surgery for a few years there, a very basic surgical training. Then he was awarded a traveling fellowship from the Rovere International that allowed him to move to the Royal Marsden and to spend there one year of experience in 1977. He moved with the family, with the two daughters and the wife. And after that, he went back to Italy for a couple of years, but then he realized that probably his career would have been developed in the UK. So he went back to Epping, where he assisted, working with Mike Morgan, in setting up one of the first screening units in that country. And then he fought a lot to get his titles recognized by the United Kingdom, his Italian titles. And eventually, that was a case court that has set the precedent for European doctors who wanted to practice in the United Kingdom until Brexit happened, obviously. And I remember Querci della Rovere as a very highly skilled multidisciplinary breast specialist. I mean, he was able to read mammograms. He was able to perform wire-guided localization on his own. He was very skilled in medical oncology, and he had an exquisite knowledge even in radiotherapy. He was able to understand clinical trials, to randomize patients. So that kind of breast specialist that we want to create now. And I remember that he was a very empathic doctor. He was really able to understand the fate of the disease of the patient. He was really able to understand patients' values, expectations, discuss patients' expectations. And I may remember some breast reconstruction that was not perfect, but I cannot remember any poorly satisfied patients. They were all extremely satisfied because he was really able to understand values and preferences. And also was a man with an extraordinary personal balance. I met him for the first time. I started there, the Marsden, in 2001. And he had already a severe illness, but he told me, but I couldn't have never realized that. He was perfectly working, never complaining, with an excellent balance. And also he was a very well-read man. He was an expert of philosophy. He was a fan of classical music and art. And eventually he was passionate with a philosophical current that is called critical rationalism, to whom Karl Popper belongs. And I remember this very interesting editorial that he published back in 2006, that was a critique of the sentinel node concept that at that time was considered as such a religious dogma. And he was always challenging the dogmas. It was, I mean, his personality was always challenging dogmatic teaching. And this was particularly true with this editorial that was highly criticized at that time with a reply from Cody. And he had very clear in his mind the paradigms of breast cancer growth. And I remember that we had a lot of discussions, especially regarding this topic that was published on the Lancet Oncology, regarding the two classical paradigms, the Alstidian paradigm and the biological paradigm of breast cancer growth. And he was claiming a paradigm in the middle that could have explained the effectiveness of screening and again, the scientific value of the theory of sentinel node biopsy that could have been in another way an Alstidian concept. And eventually, a few years after his death in 2009, in 2016, this paper was published by the colleagues that followed him at the Royal Marsden, so by Miss Jenny Rasby and Peter Barry and the team from the Royal Marsden in Sutton. This paper is showing how in the early years of this century, he had anticipated all the, the inspiration regarding preservation of axilla, of the axilla. And so they had the chance to publish quite a long-term follow-up in 2016, a few years after he died in 2009. So the International Fellowship Querci della Rovere is meant to provide opportunities to follow his path. The same opportunities that we have been given by Querci della Rovere, like me, like Professor Lorenzo Orzalesi in Florence, or Mr. Riccardo Bonomi in the United Kingdom. And again, this is a matter of skills. So we organized this fellowship providing a job and so on at the level of a senior registrar. Most of the applicants and all those who have been appointed are post-CCT, working six months at the Royal Marsden Hospital in London, in Chelsea, under the care of Miss Fiona McNeil, Miss Jenny Rasbinow, Nicola Roche, who was one of the fellows of UCHO when I was at the Marsden in Sutton, and Mr. Geragui. And then they moved to the Adam Brooks Hospital in Cambridge, where they find Professor John Benson, which is one of the most relevant consultants and is the leader at the moment of the International Fellowship, Mr. Amit Agrawal, who participated to the iBreastBook webinars, and Professor Charles Malata. And they have the chance to practice oncoplastic surgery at a very high level in two of the most renowned breast units in the United Kingdom. And then Mr. Querci della Rovere believed in internationalism. I asked him if he had a British passport after living for about 30 years in the United Kingdom, and he told me, I don't need it because I have the Italian one, and everybody can realize that I'm Italian because of my accent, because of my culture. But I'm also British because I've been here for 30 years, and this country has offered me a great opportunity to develop my career. So the passport is something that I need just to across the borders and nothing else. We really believed a lot in internationalism, and we wanted to offer to the fellows the possibility to create networks abroad. And so we offered 1 month observership at the National Cancer Institute in Italy, in one of the historical breast units in Italy, the one that in which Professor Veronesi started his historical trials, the Milan 1, the Milan 2, and the Milan 3. And then they moved to New York at the Memorial Sloan Kettering Cancer Center for another 1 month observership with Professor Peter Cordeiro and Professor Sacchini in the breast service. Cordeiro in the plastic surgery service and Sacchini in the breast service. And we want a complete oncoplastic surgeon that should have also academic skills. That's the reason why we organized masterclasses, conferences, scientific lessons of teaching of effective scientific writing. And one of the masterclasses we organized was held in Giarre, here in Sicily, in 2018. And a very small number of participants, young participants, had the chance to meet with senior key opinion leaders in a multidisciplinary setting during a weekend in a very nice place with a handsome landscape, staying all together, communicating in a very free way, in a very relaxed way. And we had teachers from the European Institute of Oncology. We had Professor Isabel Rubio, plastic surgeon like Maurizio Nava, who is the head of Greta, the honorary chairman on Greta, and Professor Benson as well. So a possibility to discuss directly with key opinion leaders, and also the possibility to organize talks, share their opinions in a very live, in a very effective way. And then the following year, in 2019, we organized a new masterclass. This one was absolutely interesting because we organized a masterclass on medical treatment of breast cancer without surgeons. We had only Professor Benson and Maurizio Nava. But that was very interesting because we exposed our fellows to medical treatment, to biomarkers, to modern trials on neoadjuvant chemotherapy, and also to trials of metastatic disease. And we had a very in-depth discussion with all senior key opinion leaders. We had Professor Curigliano, who was the co-chair of the St. Gallen Conference, and we also had Professor Luca Gianni, which is one of the most important medical oncologists in Italy. That was really an exciting experience that, unfortunately, in 2020, we had no chance to repeat because of the COVID. And again, we gave to the fellows the chance to develop effective scientific writing. And for instance, Wafa Taher, which is one of the former fellows of the International Fellowship, came to my hospital and contributed to this study of principal component analysis to assess the shape of the breast. And again, we had also Aisha Khan, who came to Catania to visit my unit for a couple of weeks and developed with me a paper on the escalation of oncoplastic surgery. So these are the outcomes. We had a global field of applicants from all over the world, from Australia, from South America, from Europe, of course, but also from Middle East and from Central America. There is a median of 7 shortlisted candidates each edition. The interviews are normally held in London. You can see here the panel with me, Miss Fiona McNeil and Professor Benson, but obviously we can organize an online interview for candidates from overseas, from Australia or from Asia and so on. And so far we had 12 candidates appointed, 8 completed. One had a post as a consultant surgeon after the first 6 months in Cambridge. Another one had to leave because of the coronavirus. She preferred to go back to Australia quickly, and 2 are currently ongoing. And these are our fellows. They are from various nationalities. Most of them are from the United Kingdom. We had 2 Italian fellows and 2 from Jordan and 1 from Romania. And these are the 2 currently ongoing fellows of the International Fellowship Querci della Rovere. What are the developments? First of all, we would like to offer to our fellows formal recognition of BRESO Tier 2 as a BRESO Tier 2 training. And I'm personally convinced that it would be very useful to give even more multidisciplinary training. And in my point of view, they need a lot of training, especially on the side of medical oncology, biomarkers, and neoadjuvant trials. And personally, this is my point of view. I would like to see in the next future more interaction between medical oncologists and surgical oncologists to optimize the surgical outcomes. And finally, we want to improve as much as possible the refinement of surgical skills. So I'm available for any question. You can navigate, you can see our socials, the socials of Greta, and we can give you any kind of information, and I will be happy to answer to your questions. Thank you for your attention.
Many thanks, Giuseppe, for a great talk. By the way, I always wanted to apply for your fellowship, but I couldn't because my wife will kill me with the 2 kids to move all across across the world. So it's a great fellowship, and I had the pleasure of post-CCT going to the Royal Marsden and working there, a great place to work. I think we'll just do all the talks and take then the rest of the questions if that's okay with everybody. And we talked about UK fellowships, we talked about fellowships that happen in Europe, and it's always worth mentioning that there's some other fellowships in Europe, especially there's some ESSO fellowships. There's a great fellowship in Guy's and St. Thomas's. There's a fellowship also in Manchester that are approved by ESSO. And also there's a 3-month fellowship that is in Budapest in Hungary. And if you see Zoltan Matrai and his colleagues, they presented their work last week in a conference in India, and the techniques that they do is fantastic. The work that they do is really fantastic. So those are all things that are worth looking at if somebody is looking for fellowships. Last but not least, we have Patricia Clark, and Patricia is going to talk to us about fellowships and breast training across the pond in the States. So are we different or are we very similar? I will hear that from Patricia. The floor is all yours for the next 15 minutes, Patricia. Thank you. I think your microphone is on mute, Patricia, till now. You need to unmute your microphone. It's usually in the lower left part of the screen.
Got it.
Yes, that's great.
We're back on track. Let me see if I can get this screen shared. And we should be good. Okay, we should be good. So I'm going to talk today about fellowships in the US.
I think the screen is not shared yet, Patricia. Do you mind sharing the screen?
Yeah. Great. Let me go back. Shut this down. How about now?
No, not yet.
Not yet.
You see the share screen button at the lower center part of the
screen? Yeah, that's the one I'm hitting. The slideshow. Let me get, here we go.
It was quite okay earlier. So
right. I'm so sorry.
Right.
I apologize to the whole audience. We had a dry run on this. I was able to do it. Okay, we good now?
No, it's still, there's no screen.
It's still no, okay.
So share, yeah, that's that. We are all good now. That's great. Thank you.
Okay, well, these talks that everybody has given are just wonderful. Thank you for giving me the opportunity to let you know what's going on in the US. My practice is heavily, oh, now I need to, anyway, my own practice, I do quite a bit of oncoplastic surgery, and I've become very interested in training programs just because of that aspect. The Europeans have been quite a bit ahead of the United States traditionally there. So our US programs, I have no disclosures pertinent to this talk. In the US, our general or our breast surgery workforce is made up of general surgeons and fellowship trained breast surgeons. Unlike in Europe, we don't have a certifying board or a certificate to practice breast surgery. Traditionally, surgeons in the United States did a 5-year general surgery training program where there were index cases that you had to meet for breast surgery just to sit for the general surgery oral boards. As some of the previous speakers have talked, in breast surgery, it's become extremely complex where our algorithms branch pretty finely. We have advances in radiation, advances in radiology, advances in medical oncology, advances in reconstructive surgery. And it's become very clear internationally that just under the scope of a general surgeon, I think a little extra training in breast surgery is indicated. The American Board of Surgery has they sanction 24 medical boards. The general surgery takes 5 years, and after sitting for both general surgery written exam and oral exam, there is a continuous maintenance of certification that lasts, that we do for about every 2 years. We have just recently changed that to specialty specific. So breast surgeons or general surgeons who are practicing just breast surgery and really don't practice the broad range of general surgery, they can take an open book test now to maintain their certification with half of those questions just being breast specific. So we're moving forward that way. In 2014, we started our first, I take that back, in 2004, we started our first breast fellowships, which were sanctioned by the American Society, I'm sorry, they're sanctioned by the Society of Surgical Oncology. Our only accredited fellowships are accredited by the Society of Surgical Oncology. that is the Society of Surgical Oncology sort of falls down under the American Board of Surgery. So you do not need breast surgery certification to practice breast surgery in the United States. All you need is general surgery training. So these approved breast oncology fellowship training programs were first conceived and put together by the Society of Surgical Oncology, the American Society of Breast Surgeons, and the American Society of Breast Disease. The American Society of Breast Disease no longer exists. So these are now administered by the Society of Surgical Oncology, and the American Society of Breast Surgeons contributes to the curriculum. There are 60 programs in the United States now. What is happening in the workforce is the major metro practices pretty much require fellowship training certified by the Society of Surgical Oncology for just employment. Most of the rural areas in the United States, breast surgery is still performed by the general surgeons. So the curriculum, this term mastologist, I see this quite a bit in South America. And I just threw this in because it's a good concept of how we look at our fellowships here in the US. So they're very broad-based, they're very multidisciplinary, and half of this is not even in the OR operative experience. So we have rotations and experience required in medical oncology, radiation oncology, pathology, plastic and reconstructive surgery, genetic syndromes, including genetic counseling, breast imaging. Our fellows do rotations right on the radiology services, palliative care, end of life, psycho-oncology. It's more of a holistic whole body experience. We need to be competent in benign diseases and conditions as well as malignant. There is training for clinical and basic research. Some of this includes writing papers, presenting at national meetings. Community outreach and leadership are important. Cancer rehabilitation, lymphedema management, billing, coding. So it's a very comprehensive one-year program. We do have essential common procedures that we have actual numbers, case log numbers that you must submit to graduate. So in medical oncology, there will be rotations on that. We have to do at least 15 follow-up visits are the minimum requirements. Radiation oncology, our fellows need to see at least 15 new breast cancer consultations, 5 new breast cancer or recurrent breast cancer simulations. So they are right there with the physicists doing the SIMS and physics reviews. So we want that to be a fairly robust part of the training. In pathology, they actually sit there at the bench. They do the case from A to Z. They have to do at least 8 breast cancer case sign-outs. They need to do at least 8 frozen sections or intraoperative evaluations and 8 benign or high-risk lesions. Plastic surgery, they need to do at least 8 reconstructive cases. They don't need to have actually been the primary operating surgeon on these, but they have to have exposure to these. And then they have to have a genetic counseling component where they've at least observed 3 consultations. And then in breast imaging, they do a rotation in breast radiology. They need to do 8 screening cases, 8 breast ultrasound or nodal ultrasounds, 8 diagnostic mammograms, and 8 breast MRIs. And these essential ones, as you can see on breast ultrasounds, they need to have hands-on at least on 15 up to or 30 observations. Some of our programs, the radiology departments they have an exclusive on radiologic procedures. And so that makes it a little bit tougher for the breast surgeons to get experience in actually performing things such as these percutaneous procedures. So they can be present and they don't actually have to do these, but the percutaneous procedures they have to be familiar with are fine needle aspiration, cyst aspiration, core needle biopsy, seroma aspiration, and abscess drainage. We need to do at least one major ductal exploration, partial mastectomies or diagnostic excisional biopsies, 50 of them, including oncoplastic partial mastectomies, at least 40 spread over all categories. They should be doing nipple areolar sparing mastectomy, skin sparing, total mastectomy, but it can be any combination of these. Axillary node biopsy or sentinel node biopsy, they need to do at least 50, and they need to do for axillary node dissection in particular at least 10. And as some of the other speakers have mentioned, axillary surgery numbers are becoming increasingly more difficult to achieve as we stop doing so many axillary node dissections. These uncommon procedures that are essential to know, we don't have a defined number of cases that you have to know, but you should have exposure to this. So level 3 node dissections, palliative mastectomy for stage 4 disease, chest wall recurrences. In plastic surgery, this is kind of a little laundry list of what you should be exposed to. So the local tissue flap closure for tissue defect, breast reconstruction with and without tissue expanders, expander exchanges, autologous tissue transfers, pedicled flaps, tram flaps, free flaps. I don't know why I've got tram under free flap. That's a little mistake there. But nipple reconstruction, areolar tattooing, breast reduction, and mastectomy for symmetry. And then these complex procedures, this is just experience as available. So vacuum assisted core biopsies, some places are not even doing this, secondary to changes in reimbursement structures where some people have just dropped the vacuum assist completely. Clip placement, placing localization wires or seeds, tumor ablations. We're doing some cryo here in the US, and subcutaneous mastectomy for gynecomastia or anyway. And then this is, out of these 60 programs, the experience can be fairly variable because we have a core curriculum that is set, and then different programs will have areas where they shine. So I just put up samples from Cleveland Clinic, New York University, and you can see where they can structure these a little bit differently, where Cleveland Clinic has, specific, you're 7 months on a surgical rotation, medical oncology 1 month, radiation oncology 1 month, et cetera. And then as I move through this, we have a matching system. So the match is done through a national program now where everybody submits their application materials to the national matching services. And that's done in January and February. Interviews are all preset, and they run from April to June. The programs and the applicants send their rank lists in June and July, and then July 30th at noon, the match results are announced. These are emailed to all of the candidates, and then they're put on the websites. And we start the fellowships August 1st. So one of the things that has come up here quite a bit, we've talked quite a bit about oncoplastic surgery. And what has happened in the US is still over half our patients are getting mastectomies, but the degree of surgical training that you need to be successful in breast surgery practice now is becoming more and more, it's becoming higher and higher because of the reconstructive options, because we're now reconstructing lumpectomy defects with the oncoplastic procedures, and our plastic surgery reconstructive procedures are becoming more advanced. So this requires a higher level of training. Our oncoplastic training opportunities in our US programs are fairly limited still. One of the reasons they're limited is we don't have a lot of faculty that are trained to do the level 2 or more advanced procedures. Most of our training programs are at major academic centers, but they're privately funded through philanthropy, as our graduate medical education is only federally subsidized through 5 years of the general surgery training. The American Society of Breast Surgeons is trying to do certification programs to help hospitals, even credentialed surgeons who are doing oncoplastic surgery. In oncoplastic surgery in the US, the majority of our credentialing at the local hospitals requires board certification in plastic surgery before doing a reduction mammoplasty or a mastopexy. So the American Society of Surgery is just starting to put together criteria to help our breast surgeons go to the credentials committee and say, I'm qualified to do this. I think what it's going to take is it's going to take some of the fellowships that you've talked about that are already set in Europe to train some of our faculty to come back into our breast surgery fellowships and start training into these higher levels. Our plastic surgery leadership is acknowledging that it is appropriate for breast surgeons to do level 2 oncoplastic procedures, but our main challenge here is still getting the operative experience to become competent in that. So that's sort of the difference in our American training compared to yours. Is I think we're trying to train very broadly trained breast surgeons in all aspects of breast disease. And when it comes into some of the more advanced surgical techniques, I think that our more advanced surgical programs development is still to come. So that's that.
Thank you, Patricia, for the talk. Thank you for the lovely talk. Do you mind just stop sharing screen, please? And I don't know if everybody's still online from the faculty. There's few things that I need to mention to the participants, and then we go with the question and answer section, as there's quite a few questions that we can address. You're still sharing the screen, Patricia, so the easiest way is to go on the lower end. Yes, that's great.
Sorry.
That's great. Now, many people are asking for CPD certificates. There is 2 hours CPD accredited for this webinar by the Royal College of Surgeons of Edinburgh. If you want the certificate, please just reply to the follow-up email that you get. I'll send you a feedback form, and when you fill that, you send the certificate. I'm trying to do an online feedback form. So when this finishes, you will have a pop-up survey. Fill that, because if that works, that might save you to fill the actual paper form that I send you to get the certificate. Now, may I just go back to, there's lots of questions for Prof Masia and for Sue about the masters and the fellowships. And people are asking, for example, about the masters with Prof Masia, about is there more than one center in Europe, and is it open to non-Europeans? And I answered that it is open to non-Europeans. Am I correct in that, Prof Masia?
Yeah, that's... our master is open to everybody who wants to know. In fact, even one of our priorities, and always we leave some of the places reserved for emerging countries. Because, if you want to learn in Europe or in US, you can. There is no reason, for not learning if you are European citizen or you are American. Because you can travel, you can go. It's something that depends on you, but it's extremely difficult for some places. Emerging countries, South America, Middle East, some places in Africa. And this is one of our priority, because our priority is not only to provide, the best practice. We need to provide the best education to all the world to extend this quality of the breast surgery around the world. And this is why 35% of these places, there are always priority for emerging countries. This is the second answer is we try to increase always the best places for training. It's not only the Barcelona, the Catalan, or the French. Is the people they can see the French view, the UK view, the Spanish view, the Italian. We have all our fellows. They are moving around different centers in order to see and to provide this, open, mind approach. And this is essential. And the most important is learning. It means not is reading, is not accreditation. Only way, we provide education.
That's great to know, Prof. And Sue, I know that you have two different programs. One is mainly for the UK-based trainees, but you have the international program now that we have people from across the world also that can join. Am I correct in saying that?
Yeah, you're correct, Yazan. The initial MS program was based really for the UK and Europe because we required people to travel face-to-face for the practical OSCE examination. And then we started the MCH program, which was the equivalent surgical masters for international students, which didn't require any travel. So you could be accessed anywhere in the world. Now, obviously with COVID, now that we're moving to an online OSCE, it may be that we will merge both courses and be able to offer them as a single course in the next year or two. But at the moment, the MS program, the original MS program, includes practical competency assessment. It's assessment of your logbook, assessment of your practical competency as a surgeon, but the MCH program is just theoretical competence, decision making, and communication skills.
And the great thing about the panel today is that we have Lynda, who used to be the chair of the Education Training Committee in ESSO, and we have Anne Tansley, who is the current chair of the Education Training Committee of the Association of Breast Surgery. Lynda, the exam, the European Board in Breast Surgery, also the same question many people are asking, is it open for everybody?
Yes, there's no restriction on your country. You have to be able to speak English because the exam is in English. But every year we have candidates from India, Egypt, Pakistan, South Africa. So it's not strictly limited to Europeans.
And always ABS has been very supportive of trainees doing those degrees, doing the fellowships, because ABS was the main driving force with BAPRAS behind those national UK fellowships. Some people are shying away from doing the fellowships. They just want to do the training and then get their CCT. And if those fellowships are becoming post-CCT, are going to shy away from them. What's your thoughts about that?
No, I don't think anything will change. There may be one or two trainees who wish to take up a consultant post for personal reasons. But the new curriculum is going to be such that there will be likely a maximum of 4 years training in breast surgery in the UK. So I think that there will still be the need to develop skills post-CCT, as we all do as consultants. It's just called CPD. So I think there will be still the same interest in applying for the gold standard fellowships to broaden their experience. And I notice and have replied on the question and answers, there's a lot of discussion around how post-CCT you will be or you can be to apply for our fellowship scheme. And although we're developing the detail around that currently, it is likely that we will expect trainees to apply immediately after CCT. So you'll do your CCT and then you'll go into a post-CCT fellowship. So the program will be pretty much the same as it is now, because currently our trainees actually extend their training program so that these fellowships can be labelled as pre-CCT fellowships. So it's essentially going to be exactly the same program with a slightly different name.
Because there's lots of questions from the audience about criteria to enter those fellowships, and we'll address that in a minute. But from the trainee's point of view, Edward, you just finished training, you're a consultant now. If you did not have any further advanced training in oncoplastic breast surgery, where do you see people that just finished the basic surgical training, did not have the technicality and the training to do something more advanced? Where do you see their careers in 10 years' time?
Yeah, so I think, you know, the last 2 hours has just really highlighted how much breast surgery has progressed over the last couple of decades, and has just demonstrated that you can't really be a breast surgeon without knowing these advanced skills, I don't think. And so, you know, we've heard many different ways tonight about how you can gain further experience. And I'm sure that around the world, as in the UK, we're thinking about how we can offer a better breast surgical training as individuals, and can we have, and should breast surgery be more of a standalone specialty in its own right? But in summary, no, I think you have to go through one of these forms of specializations in order to be a breast surgeon of the future.
A very common question is about who can apply for the fellowships. Giuseppe, who can apply for your fellowship?
Okay, I've tried to reply directly to those who asked. Normally, we accept candidates who are post-CCT, who have qualification to work hands-on in the United Kingdom because they have to deliver a service in the NHS. So most of the times, these are candidates who comes from at least an experience in the UK system, like the 2 Italian guys, they had previous job in the NHS. And normally we appoint candidates who have good academic, I mean, who would like to develop an academic career. And also they should be prepared to travel without, I mean, no problems traveling to the United States or to Italy. But these are normally our candidates.
Because many people are from the Middle East, they're from the subcontinent, from South America. And what we're talking about is something that will happen in the UK. And also it's talking about, Sarah's talking about something in the UK, and Patricia's talking about something in the States. Any comments about that, Omar? Because there's very few opportunities for people from outside those countries to train further.
Yes, actually, I wanted to make a comment to what Lynda was mentioning, as well as Jaume. And I have been working with the European board exam for almost the past 10 years. And we have seen a lot of graduates from within Europe and from outside Europe. We have seen how the European board exam has built itself. We met each other, Yazan, in this exam, and we came to know each other through this exam, and how it's being expanding and how it's getting more candidates from all over the world. And this is one very important thing. It's a European degree, but it's open to everyone. This is one thing. And the other thing, what Jaume Masia was mentioning now about giving opportunity for Middle East countries and countries where training is not that easy to be conducted. And I would like to actually thank Jaume, because he's training now one of my team members who has been working with me for the past 7 to 8 years. Ali Sakaf is one of the excellent surgeons from Yemen. And actually, what's important is that sometimes he used to have difficulties in traveling. After 2011, these third world countries and our countries became sometimes difficult to travel, not only to find a good job, but just to travel for 2 weeks. And what I've seen with what Jaume is doing for Ali Sakaf, one of the excellent surgeons from Yemen, and all his other colleagues, is actually fantastic. And for that, I would like to thank him and for all what he's doing. And one last thing is that if we all have gathered here 5 years ago, we wouldn't have had this knowledge about training and understanding and concepts. Actually, we would have been all talking about surgical techniques and skills. And this describes very well how breast surgery has evolved. Now we can sit 2 hours to share experience about training without mentioning one single technique that is like we used to do in the past. And this tells us where we are going now. We are going to the next level of precision, education, standardization, guidelines. And actually, I enjoyed it very much, Yazan, and I would like to thank all the speakers. Thank you.
Sorry, Yazan, can I add a comment, please?
Of course, Giuseppe.
Yes, we had 2 appointed candidates from, they were Jordanian. And one is Wafa Taher, she's working in the UK, and the other one is Mahmoud Daka, who has gone back to Jordan. So, I mean, as far as a candidate from Middle East is concerned, we are very happy with this, because he's bringing back his training, his UK training, and the training from the International Fellowship to his country, which is something that I've done in my country. Okay, so in our point of view, is a great success.
Giuseppe, I'm originally from Jordan, and I was texting Mahmoud yesterday, and he sends you his regards, by the way.
Okay, thank you, thank you.
And but that's all about opening opportunities for people, not only for the UK and also the rest of the world. Sarah, I remember when I applied for the National Oncoplastic Fellowships, it was UK only trainees, was mainly England and Wales, because it's funded by Public Health England, but then they opened it to Scottish and Northern Ireland trainees. But is it open now to more people to apply for those National Oncoplastic Fellowships?
Unfortunately not. I'm sad to say that the TIG fellowships are only available to those within the UK. So Ireland, Scotland, Wales and England as things stand. I am very supportive of both Sue and Linda's approach that's international. I've shared all our documentation, and I will do my very best, as you are doing in terms, Yazan, with your iBreastBook, of spreading the message as wide as we can and being as inclusive as possible. The TIG fellowships are only available within the UK as things stand at the present, though.
There is some ESO fellowships. A couple of them are in the UK. One is in Guy's and St Thomas's, and one is in the Christie's in Manchester, I think. And they're open for people to apply. And there's a couple of other fellowships that are excellent. I mentioned the one in Budapest, and I'll mention it again because I think what Zoltan does there is really great. And if you see their operative techniques and their results, it's really great. So those are things that are really worth looking at. And there is some other non-TIG fellowships and MTI jobs that open opportunities to people to come from outside the UK to the UK for further training. Patricia, for the US fellowships that you mentioned, are those only for people that have the American Board in General Surgery and then they can go to those fellowships, or can you match if you have something other than the American Board in General Surgery?
Yeah, that's a good question. I don't know the answer to that, but the thing with the US is you have to do, before you can do the surgical procedures, you have to complete that 5-year general surgery. Just for credentialing purposes. So the US, when it comes to training, getting your surgical training outside of the US, you need to come back in and repeat those initial fellowships first.
And
So
I think we're now 2 hours into this webinar. We still have nearly 200 people online, which is great. But I think we come to the end of this. Anybody with final comments? I cannot thank you all enough. You've been great. It's a pleasure to see you all online, and many thanks for everybody that has logged in as participants also. Thank you again. There's lovely webinars for next year. We are working with Senator now. There's a couple of very interesting webinars, some technical and some are knowledge-based. So I will share all that with you with the follow-up emails. Very interesting faculty, surgeons, oncologists, and plastic surgeons. Have a lovely evening, and thank you all for logging in.
Thank you, Yazan.
Thank you, Yazan.
Thank you. Thank you.
Thank you.